like to introduce Dr. Wendy Dean to all of you. If you don't know Dr. Wendy Dean through the amazing podcast, Moral Matters, that she has with Dr. Simon Talbot, I encourage you to go to her website, moralinjury.org, or go to Moral Matters, the podcast after this, and check that out. That is where I first learned about Dr. Dean and the amazing work that they're doing around moral injury. And it was just really a godsend for me, I found, as we navigated the pandemic. And I really struggled with a lot of the work that I was doing in the health authority. And so please go check that out. But Dr. Dean is also a former emergency room physician and a psychiatrist. And she's really spent the majority of her career at that intersection of medicine, business, and courageous creativity, which I absolutely love. Dr. Dean has also had several leadership positions, including overseeing medical research funding and guiding strategy for the U.S. Army. And now she's focused on finding innovative ways to make medicine better for both patients and physicians. And since 2019, she's turned full attention to addressing moral injury in healthcare. And tonight she's going to talk about the knowledge she has and the experiences that she's had around moral injury, and share some solutions with us to lessen its impact on clinicians and on the healthcare teams that we care about so much in our healthcare system. And so with that, Wendy, I'd like to turn it over to you and give you the majority of the time this evening.
Thanks so much. Let me just pull up my slides here. I really appreciate the opportunity to be here and speak with you. I'm going to tell you a little bit about our journey, my journey with my co-founder, Simon Talbot, and what we've learned in the last 5 years. Well, it's more than 5 years now. It's about 7 or 8 years that we've been talking about and thinking about this work. And then I'm going to do my best to keep this conversation this part of the conversation fairly short, 30 minutes, 35 minutes, so that we save plenty of time for question and answer. So I know that we're going to stop the recording, but while you're listening, so it can't be quite as informal as but while you're listening, if questions are coming up, feel free to put them in the chat so that at the end of the talk, we can pop right into questions. Oh, hang on, we're not advancing. There we go. So I'm going to talk a lot about the intersection between clinicians and administrators tonight. But one of the things that I really want to make sure that everybody understands is my perspective that no matter who you are in healthcare, from environmental services to clinicians to administrators, there is something about this work that draws people in. And I think there are very, very few people, there are always a few, but there are very few in healthcare who come here for reasons other than to participate in healing. So I just want that to be the setting conditions for how you listen to what I say today. I started my career as a surgery resident. And I got about 3 years into the residency. I loved what I was doing. I thought like a surgeon. I loved the procedures. I was good at it. But I also realized that it was not going to be the thing that I could do for the rest of my life and do the other things that I'm interested in. So I took a step back. I left my residency and I went and spent a couple of years working in an emergency room in the far northern reaches of Vermont and New Hampshire, right up against the Eastern Canadian border. And during that time, I thought about, who are the patients who are coming into me, and what are the conditions that I find most intriguing and that I think I could do for the rest of my career. And it turns out that it was the psychiatry patients that I thought were the most fascinating. And so I went back to a psychiatry residency. And when I was done, I went and worked in one of the busiest emergency rooms in the US as an emergency room psychiatrist. I lasted there for about a year and realized that the business structure of that healthcare system didn't allow me to care for my patients the way I had been trained to do. I was asked to transfer patients who had public health insurance elsewhere. I was asked to keep the private pay patients at our hospital and send the others out to the public community health center. And I really struggled with that. So then I went and I went back to the area where I trained so that my husband could start his second residency. And I hung out my own shingle. And I could take care of patients. I then had control over how I saw patients. I could do therapy and medication management together when patients needed it. I could work with some of the really high quality therapists who were in the community, but we could work tightly together. And I felt like it was a really good balance because I could also see patients on a sliding scale. But when my husband finished his residency and we moved again, I went to an area that didn't have quite as much disposable income and where insurance policies weren't so generous. And I quickly faced the question of, can I make a living doing this work, or do I need to shift to doing just medication management, give up on the therapy piece because it doesn't reimburse well at all for a psychiatrist. And to me, that was not a choice that I could make and be comfortable with. I did not want to see patients every 4 to 6 patients an hour, and wonder whether I had missed something, and wonder whether the therapist that I didn't have time to coordinate care with was picking up on everything that I had picked up on. At that point, I went out and I left clinical practice, as I said, and I started working for the US Army. What I was doing there was managing research funding oversight. We were deep in the wars in Iraq and Afghanistan. We were seeing devastating injuries to service members. And my job was to oversee these innovative programs that were trying to take regenerative medicine principles and apply them to wounded service members. Completely unrelated to psychiatry, but it drew on my emergency room and surgery background. What it also did, though, was to give me a window into how healthcare funding works, the business side of healthcare, and how we pay for the treatments that we provide. Around that same time, so, I was coming to realize that in retrospect, a lot of the changes that I had made in my career were trying to find ways to take care of patients the way I was trained to do, and to find ways around some of the business structures of healthcare that tried to constrain my care. So I came at this sense of clinician distress from a clinician's perspective, but I also came at it from the perspective of a family member. In late 2016 and 2017, my husband became critically ill. And while he was in the hospital, and I was pleading with them, it was a local hospital, I was pleading with them to please send him down the road, 2 hours down the road to the academic medical center. And for whatever reason, his clinicians had no sense of urgency about transferring his care, even though he has a complex congenital cardiac anomaly that they were clearly not equipped to manage. And I couldn't make sense of why they were so paralyzed. And it sent me down a path of curiosity. Around the same time, I started talking with Simon Talbot about his experience of healthcare. He is an academic plastic surgeon, arguably maybe the polar opposite from what I was experiencing as a psychiatrist. If you think about, if you think about sort of the spectrum of clinical practice, he was at one end, I was arguably at the other. And yet, the more we talked about what our experience of medicine had been, we realized it had been incredibly similar. We also realized that we had both thought that even though initially when we came to medical school, we thought of ourselves as pretty tough, pretty resilient, very resourceful, that we had assumed our inability to really thrive in our careers was because of us. And the more we talked, the more we realized, wait a minute, if two people from this opposite ends of the healthcare spectrum can have the same experience, maybe it's not about us. Maybe this is actually about the system. So then we started thinking, okay, hang on, like maybe this is the two of us, but maybe it's not other people. Maybe we should ask folks. And so we started asking people in our circles. And at this point, my circle was across the country, people in academic medical centers who were doing this cutting edge research for the Army. They were at some of the most accomplished physicians I'd met. They were at some of the best institutions in the US. And yet they were telling us the same stories. I love my patients. I love the medicine I practice. It's everything else that gets in the way. So we talked to Mary Franco, who is a nurse practitioner who went to the physician who employed her and said, I know I promised you I would work another 4 years. I can't do it. I cannot, in good faith, practice in a setting in which I can't even make eye contact with my patients because I have to spend so much time in the EMR. How can they trust me if I can't even look them in the eye? So she left 4 years early. I talked to a doctor I'll call Rita Gallardo, who said she left 2 positions within 5 years because she was being asked to do things that she didn't think were best for her patients. Namely, she was not allowed to refer outside of her own healthcare system. So if a patient had a particularly challenging diagnosis that she knew her mentor an hour away was the best person for, she was not allowed to do that because he was in a different system. She had to make her referrals to her colleagues in her same healthcare system. And she said, I can't do that, and walked away and hung out her own shingle, and is trying to make ends meet, starting up a brand new practice. We talked to Keith Corll, who is an emergency room physician and a pulmonary critical care doc, who got fed up one day when he went into the room. His emergency room had providers in triage. And so there was one day when he went in to see a patient who had a complaint of chest pain, had the $1 million workup for cardiac issues. And the man lifted his shirt and he had a shingles rash. And he said, I've now inflicted $8,000 of emergency room bills on this patient, and he didn't need any of them. How can I keep doing this? And then Isabella Rodriguez, who is a psychiatrist in Western North Carolina, who said, I trained for 25 years to learn the gold standard of care. And the minute I walked out into practice, I had to compromise that care because we don't appropriately fund mental health care. And she said, I knew I was signing up for long hours. I knew I was signing up to see impossibly hard things. What I didn't know was how hard it was going to be for me to get my patients the care they needed. And that breaks my heart. So when we heard these stories over and over and over again, we asked these clinicians, so are you burned out? And I'm sure that all of you have heard about burnout by this point. It sort of seems to be ubiquitous in healthcare, no matter who we talk to. And it's a constellation of symptoms: exhaustion, ineffectiveness, or lack of accomplishment, cynicism, or detachment. And we would ask these folks, okay, so you're burned out, right? And they would say, well, I mean, I don't know what else to call it, but it doesn't feel quite right to me. Like, I don't feel like I'm incapable of doing the work I'm asked to do. I don't feel, I knew I was going to have these long hours, but there's something else going on here. I just can't put my finger on it. But yeah, okay, I don't have better language, so I guess I'm burned out. And they were telling us that it was the usual burdens that they had. They were struggling with practice metrics or productivity. Can you increase the throughput of your emergency room? Can you see more patients in your clinic? Your access is too low. Can we bump that up a bit? The electronic medical record that separated them from their patients during the day, like Mary Franco, and from their families at night when they were trying to catch up on clinic charts. They were trying to meet a standard of high patient satisfaction, because that, at least in the US, that impinges on our reimbursement. And as everywhere, they were trying to do it with less staff, less autonomy, and less latitude than they thought was useful or appropriate. So they knew that what they were signing up for, they were struggling to take care of patients the way they were trained to do, and it was breaking their hearts. I was looking for, I had spent about a year talking to various people, bumping up against this feeling like the burnout wasn't quite the right language, but I also didn't have any better language for it. And I happened to be doing some therapeutic weeding, because on this place, there's a lot of weeding to do. And I had public radio keeping me company, and there was an article about this thing called moral injury. And it was about drone pilots. We were still in the throes of Iraq and Afghanistan. And this was a story about the drone pilots who were flying missions from Nevada. So they never saw combat at all. And yet they were experiencing this thing called moral injury. And I thought, hang on, if that can happen when you don't ever see combat, maybe this is something that happens in other fields. And I dropped everything I was doing and started digging through Google and everything I could find. And, that was in 2016, and I don't think I've come out of it yet. So what I learned was that Jonathan SHAY, in his book Achilles in Vietnam in 1994, was working with veterans who looked like they had the symptoms of PTSD, but they weren't responding to the usual treatments for PTSD. And he said, maybe this is something different. If we're doing what we think is right, if we think we have, we have a diagnosis, we've made a diagnosis, we think we're treating them in the way that we should for this diagnosis, but they're not getting better, maybe we need to revisit that. And what he said was, it sounds to me like they're talking about a soul wound. And the service members that he was talking to said the pattern that he noticed was that they had been betrayed. So they experienced betrayal of what is right by someone who held legitimate authority in a high stakes situation. So this was someone who was asking them to do something that was against their moral code. And then later, Brett Litz and his colleagues, including Bill Nash, expanded on that definition and said that in their work with veterans from Iraq and Afghanistan, they thought it was about perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. What we believe, these two researchers have kind of said that one is an external imposition of moral injury, and the other says it's an internal, it's sort of an internal locus of moral injury. We believe that they're related in a slightly different way. That what happens is there's an inciting betrayal. And by the way, betrayal is a big word that a lot of people kind of wince about, but really, we all are subject to betrayal. We all betray. We all will be betrayed. It is a very common human experience, and 85% of it is unintentional. So it's not the big egregious, it's not necessarily a big egregious single incident that's the betrayal. It can even be just subtle undermining over time. But what happens is clinicians experience a betrayal. So Rita Gallardo was asked to refer within her own healthcare system. That felt like a betrayal. She had two options at that point. One was to stand up and speak out, push back against that betrayal, identify it for what it was, and give those who she perceived to be betraying her the opportunity to say, oh, hang on, wait a minute, that's not what I meant. Let's talk this through and find another way to proceed. That would reduce her risk of moral injury. The other option is to acquiesce to that betrayal and transgress your deeply held moral beliefs and expectations. So in that situation, those oaths that we take, are, the deeply held moral beliefs and expectations are the oaths that we take to put our patients first. So Simon and I had found this information, talked to all these clinicians, kind of noticed a pattern of what was happening and said, you know what? We think maybe there's a different way to think about this. It's not that there isn't burnout, but that there's something in addition to it. And we put this thought experiment out in the world, which was a Stat News article that we thought would get relegated to all of the reams of burnout literature that nobody pays attention to. And instead, exactly the opposite happened. From the minute the article was published, we started getting phone calls and emails with people saying, this is the language I've been looking for the last umpteen decades. I finally feel seen. 300,000 people since then have downloaded the article. It was published in 2018, but it was the most read article for the publication in 2019, and it's still the 5th most read article ever. And this is not to say that we were so clever. What it means is that this language really resonates with folks. It hits them in a way that burnout may not. But it's not to say that there isn't burnout, and I'll explain that in a minute. So this has been sort of the trajectory of what happened with moral injury. It caught a bit of attention prior to the pandemic, but then with the strain of the pandemic, it felt to us like that was really a stress test for the system, and it really highlighted all those cracks and vulnerabilities in our system. And so it really ignited this concept of moral injury. But as I said, I want to be clear that this did not start with the pandemic. This is New York City Hall, right in the heart of Lower Manhattan. And on February 24th, 2020, I was in a small hearing room that was packed. People were sitting shoulder to shoulder on every chair that was available in the room. Nobody was masked. And we were talking about safety in New York City emergency rooms and why it was important to address moral injury. So the councilwoman who was the chair of the committee recognized already, even before the pandemic hit, that the under-resourced, understaffed emergency rooms in her city were struggling. And everything that they were doing for burnout was not quite as successful as they hoped it would be. And they needed to start considering what else it could be. And then the pandemic hit. And we're all clear about what happened in terms of the strain on our healthcare systems across the country, across the world. And I know I have a lot of clinician colleagues in Canada, and realize that you all have experienced significant strain as well. This is not, this was not isolated to one city or one country. So again, the way we tend to think about the relationship between burnout and moral injury is that burnout is the demand resource mismatch that we see in the operations of our healthcare systems. The clumsy EMR, or the difficulty in getting orders done, or the difficulty in getting resources patients need, all of those places where there just seems to be friction and slowness in the system, that drives a lot of burnout. The demand resource mismatch, the understaffing is another one. So that's on the operational side of healthcare that we definitely need to address. But then there's this other piece, this relational piece, of the relational rupture of those subtle everyday betrayals that go unacknowledged and unrepaired and lead to frustration, anger, and sort of this sense of, this is not what I signed up for, but I don't really know whether I can repair it or how I can go about that. So there are these two pieces. There's the operational fix and there's the relational fix. I don't think it has to be one or the other. And in fact, I think it's critical that we address both, but they require different solutions. And so it's important to acknowledge them separately. They also, according to research that's being done by a colleague in the UK, they are distinct entities that may occur separately, they may occur together, and they may influence each other. So the operational issues in a hospital that go unaddressed for a long time, despite clinicians speaking up over and over again, may start to feel like a betrayal. And moral injury that goes unacknowledged and unattended for a long period of time can start to look like burnout. When I show up to my hospital every day and I know that it's going to be hard to get my patients what they want, I start to feel it's exhausting, right? So that's the first symptom of burnout. When that happens day after day, week after week, month after month, and I can only get a certain percentage of my patients what they need, I start to feel ineffective. And when I watch that happen to patients over time, it becomes very painful to stay closely engaged with them. I start to pull away and I start to depersonalize. That's the third symptom of burnout. So again, they can be separate, they may co-occur, and they can influence each other. And I think the important thing about this is if you see one, you probably should look for the other. So I also, as I said, I recognize that this is not a US problem. We have heard from clinicians, a lot of clinicians in Canada, a lot of clinicians in the UK, in Germany, New Zealand, Australia, Mexico, Brazil, and several others that aren't on at the tip of my tongue. And I took a look at the survey that was posted from 2022 in British Columbia. And much like what's happening in the US, your clinicians, across the healthcare sector, folks are less engaged. They feel less effective. They're wondering whether or not they can make effective change. They still love their colleagues, think their colleagues are great. And it feels less safe to be in healthcare now. But I also want to acknowledge that this is not just about clinicians. Again, some of the work that we've done with our collaborator in the UK has shown that even administrators, 40% of administrators in healthcare systems experienced moral injury during the pandemic. 40%. If they had previously been clinicians, they were more likely to suffer it, but it didn't matter. Even if they had never been a clinician, they still were at risk for moral injury. So it's a point of commonality. It's a likely point of commonality where we can start from to find a place to get curious about the other and to start building bridges across this imaginary divide that is between clinicians, the frontline staff and the front office staff, if you will. At this point, most people are saying, okay, okay, I need to breathe and I need you to tell me what we're going to do. And I will say that none of us has ever been through anything like the pandemic before. Nobody alive who is still working has been through something like this. So if someone says they know exactly what to do, I would suggest that that may be more aspirational than it is reality. And that what we need to do is all look to each other and to start talking together about where we want to be in the future and how we want to get there. A few weeks ago, I was at a conference and there was a CEO who had been an executive in healthcare for 20 years. For the last 10 years, he had been leading a physician group. He was not a clinician himself, but he had been leading a physician group. And he said, I had no idea. I have been in this business for 20 years, and I had no idea about the barriers clinicians face, about the magnitude of the challenges that they face, or the risks associated with them speaking up and standing up. I had no idea. And he felt horrible about that. But what it said to me was that people, even who work closely adjacent to physicians or nurses or other frontline healthcare workers, unless we are very explicit with them, it is easy not to know. This is a world that we take for granted and that is incredibly opaque to almost everyone else. What he did say was, I wanted to do something. I didn't understand what the challenges were, but I wanted to do something. And that's what we hear from a lot of executives. When I was in New York, in that meeting in City Hall, an executive actually said with a straight face, we have a tea cart that we bring around to all of the floors, and we make folks a cup of tea. And that was his solution to the understaffing. Now, I don't think making tea for someone is not a good idea. I think it's a great idea. But it can't come without acting on the things that they say make their jobs harder every day. It will not be a solution for the operational challenges in healthcare. And when you make them tea without fixing the operational challenges, it can feel like a relational rupture. You don't understand me and you don't understand my needs. I would imagine that everyone on this call knows exactly how many hours they need to sleep in order to be at their best, how much exercise they need, how much family time they need to be at your optimum performance, right? We know those things. We know how to tune our high performance engine that runs healthcare, the front lines of healthcare. But when we take that finely tuned engine and we put it out on a road that looks like this, it's going to be one hot minute before your axle's broken, your tire is flat, and you're sitting on the side of the road. Or you're creeping along, not nearly as efficient as you know you can be. So again, I go back to the administrators who in good faith are saying, okay, I see the potholed roads. I think I know how to fix it. And they make assumptions. Rather than spending a little bit of extra time upfront to talk with their clinicians and say, all right, I don't do this work every day. I've never done this work every day. Tell me what it's like and what you need. Instead, they make assumptions, and that can feel disrespectful at best and dismissive at worst. Because what they don't hear is that the workforce is not asking for massive paychecks as the solution to all of their problems. What they want is equity. They want their good hard work to be recognized. And they want to have teams that they work with, whom they trust and they care about. And part of that is knowing that their leadership cares about them as well. So most of the place where we've intervened is down here at the coalface and at the individual level. We've talked about the frontline staff and how do we support them as individuals. But what we need to start doing more of is saying, how do we work up the ladder and make sure that the entire organization is engaged in this process of change and repair? And how do we also talk broader? Where are the changes in our organizations that can make our work better? And where are the changes that we need to convince society they need to make, whether with additional funding or reallocating funding, or engaging in their own wellness journey so that we have less responsibility to make sure that they are well. Part of doing that is for us as clinicians to think about expanding into spaces that we don't usually go into. Can we talk to our legislators and educate them, not to lobby with them, but to educate them about what it's like to be a clinician? Because as we've seen, if the CEO of a physician organization doesn't understand what his physicians face, you can bet your legislator may not either. And they might really appreciate understanding that better so they can make better legislation. It's also useful to be on committees in your hospital or to be on boards in your community if you can be, to influence. But it's also important for administrators to ditch their suits. Invite them to shadow you. Invite them to be in clinical spaces. And I know lots of folks who have asked and gotten pushback, but say, you know what, even if you could follow me for 3 hours on a Thursday evening, at least you will have some idea what it's like. You'll feel what I feel, and have a better appreciation for the challenge that this job is. the more we can get clinicians into administrative spaces and administrators into clinician spaces, the more we can start to break down the barriers between them. And the more we are appreciating the pressures each of us are under and how our collaborating together may work to develop better solutions that neither of us might think about on our own. My work in the Army jammed clinicians together who don't usually come together. We had ENTs with orthopedists and orthopedists with transplant surgeons and immunologists. And there were some incredible breakthroughs because they were having to think across lines that they don't usually think across and getting input from people who weren't in their typical orbits. And it really challenged them to think differently. And I think shadowing is really important to that end. In the process of shadowing, there may be the opportunity to listen more deeply with a new understanding of the framework of, oh, so these are the challenges you face. There was a hospital system in rural Missouri that in the middle of COVID said, you know what, this is unpopular in our political environment, but we are taking COVID very seriously. They shut down their gym immediately, and they put up tents in their parking lot. And so they said to their community, we are not going to let you look away from this, number one, because we intend to be prepared for our clinicians. And what they did when they shut down their gym was they converted it into not just a daycare for preschool children, but also a space where clinicians could bring their school-age children if they had to come to an unexpected shift. Their kids would never not be cared for. They would never have to worry about them and scramble to get childcare. So that was a really important way that they had their clinicians' backs. The second they noticed an uptick in violence against their workers, they didn't wait for the majority of clinicians to sound the alarm. When they saw the beginning of a signal, they put panic buttons on every single one of their clinicians. And I think that happened in early 2021. They increased their security. They even had canines in some of their locations, at least for a short period of time. What they were doing was saying, we hear your concerns and we're going to address them before you have to hound us about it. There are other systems that have done this thing called getting rid of stupid stuff. So they ask their clinicians, what are the things that are the pebble in your shoe every single day that you don't think really is that useful to clinical care? And can we get rid of it? They found 300 things. 85% of them were immediately amenable to change, and they got rid of them. They stripped it away and made their EMR easier to use as a result. So when I get to this point, I've given you examples of what other healthcare systems have done. And the typical question is, okay, so what do we do? And the truth is, unfortunately, like Tolstoy, every family is dysfunctional in its own way. And I say that in the most loving way, because we cannot have human systems without having some dysfunction in them. But what that means is the first job is to look at what's happening where you are, and what are your colleagues experiencing, and how do you bring that as a group to the people who need to hear it and can make change. And to that end, what are we all, administrators, clinicians, and patients, going to promise each other? These are just a few resources that we have out now. So The website is fixmoralinjury.org. We have tons and tons and tons of reading about moral injury. The podcast has 54 episodes now, 55 episodes. And we just published a book last week that collects the stories of clinicians who are facing moral injury, talks about the US healthcare system, although I still think that Canadian physicians could see themselves in some of what's happening here. And then talks about how some of the clinicians have been successful in pushing back. So I will stop here. Went a little longer than I expected, sorry.
Wonderful. Thanks so much, Wendy. And no worries for going long. I think it was really great to hear your story. I really appreciate the distinction between burnout and moral injury. It gives us some helpful tools, I think, for looking at what are the different ways that we look at approaching each of those problems. Just very quickly, at Switch BC, because we are a provincial organization, one of the things that we're looking at is how do we lean into this space to look at those solutions that Wendy talked about, which are really those systemic solutions. So what are the ways that we can look at system fixes that decrease the impact on individuals who work in the system? What are the ways that we support the relational piece that impacts moral injury in such a big way by providing tools and resources and opening up discussions and conversations that we can have around moral injury to create better and safer workplaces for all of our providers who are working so hard trying to deal with the challenges that they face every day. We are new, and I know probably not all of you have heard of us, but we are unique in that we bring together employers in the healthcare sector across BC, unions, as well as Doctors of BC. And so really trying to create a collaborative approach to provincial solutions that have the buy-in from all of the healthcare sector, so that once a solution is chosen and we want to roll out something, we really do have the engagement and the buy-in from all of the players in the sector. We also have the Ministry of Health and WorkSafe BC on our board, so that that full system support is there for developing tools and resources for the system. So that's really what we're about at Switch BC. And some of the ways that I think about this work is looking at how do we listen tonight to what all of you have to share with us on the challenges that you're seeing, on the things that are causing the moral injury or the burnout in your areas of work? And then how do we take that back and look at different ways that we can support a provincial lens on that and a provincial approach to that in our health authorities, in our affiliate long-term care organizations, that we can support a provincial lens on that and a provincial approach to that in our health authorities, in our affiliate long-term care organizations, and in all the places that we deliver healthcare across this province. So thank you so much, Wendy, and really appreciate you sharing your journey today. And thanks so much, everyone that's joined us.